Hi everyone, welcome to my theatre. In this movie, we will be learning about the visual field changes in glaucoma. Well, we know from the definition of the glaucoma that it is the optic disc changes and the corresponding visual field changes which forms the definition of glaucoma. So, when we see a particular optic disc change and the mirror image of it is seen in the visual field, we diagnose glaucoma. And after knowing the optic disc changes, it's important to understand the visual field changes. But before understanding the visual field changes, first let's understand what a visual field is. So what is a visual field? Well, what is a cricket field? The field where we play cricket is a cricket field. In a similar way, what is a visual field? Everything that we see in the eyes is the visual field. The way the entire area where we play cricket is a cricket field. In a similar way, the entire area that we see is a visual field. It's that simple. But unfortunately, no, it is not that simple. There is a small catch in it which we will have to remember while we are trying to understand what a visual field is. The visual field of an eye is the field of vision when the eye is fixating at a central target. So the catch here is the central target, which means when the eye is fixating at the central target, everything that we see is the visual field. So the visual field of the right eye is, for example, I am looking straight, and the visual field of the right eye is everything that I see while I am looking there is the visual field of the right eye. In a similar way, when I am closing is a visual field the right eye, then when I am looking at the center, everything that I see is the visual field of the left eye. So here the definition is simple, but we will have to understand that when the eye is looking at the central target, everything that we see is the visual field of the eye. And before okay, now you answer me a question. For example, I close this eye. Where do you think we will see the maximum? Will we see maximum upward, downward, nasally, or temporally? You just think. I mean, you just don't mug it up. Don't try to bring some information from somewhere. Just try to understand and answer me this question, that where we will see the maximum in the visual field. Well, I think most of you have thought it right, and it is the temporal side. In the temporal side, there is no obstruction, so we will see the maximum. Because upward we have the eyebrow, downward we have the zygomatic bone, nasally we have this nose, but temporally we have nothing. That's why the field is maximum temporally. And where is it minimum? Well, you will say that nasally it is minimum because the nose is there, but then it is minimum upward because we have the upper eyelid which is even closing a part of the eye. So it is maximum temporally and it is minimum upward. Okay, so this is the understanding of the visual field. And if you want to remember the figures of how much it is nasally, temporally, blah blah blah, then I have a mnemonic for you. The mnemonic is SNIT, S-N-I-T. Superiorly it is minimum, then nasally, then inferiorly, then temporally, S-N-I-T. And 50, 60, 70, 90. S-N-I-T, 50, 60, 70, 90. Okay, so this way you can remember. So here you can see that the temporally it is maximum and superiorly it is minimum. Fine. So with this understanding of visual field, I will try to tell you another concept. And what is that concept? That concept is the concept of scotoma. So what exactly is a scotoma? A scotoma is a dark area in the field of vision. Okay, a scotoma is a black or a dark area. It's a non-seeing area. Scotoma is actually a non-seeing area in the field of vision. So basically we are seeing everything, but at one point we don't see anything. We either don't see anything or we see a black patch in that area, and that is a scotoma. Why are we concerned with learning about scotoma so much in glaucoma? Because that is what we will see in the visual field in glaucoma. That's why we have to understand what really a scotoma is, so that we can understand what the patient is saying and we can appreciate from the reports what exactly the patient is, how exactly the patient has done the test. So a non-seeing area in the field of vision is a scotoma. And this scotoma can be an absolute scotoma, can be a relative scotoma, can be a positive scotoma, can be a negative scotoma. Okay? So what is an absolute scotoma? Absolute means absolute, nothing can change it. Which means the scotoma which exists even after increasing the brightness of the surrounding area is an absolute scotoma. I mean, whatever you do, the scotoma is going to exist. It is formed, it is absolute. Relative scotoma means it is relatively there, but once you increase the illumination of the surrounding, it's going to go away. So it is a relative thing. It is present, but it will go away if you increase the brightness of the surrounding. So that's an absolute and a relative scotoma. Now let us understand what is a positive scotoma, what is a negative scotoma. A positive scotoma is something which the patient says. The patient says that there is a black, I can see a black patch. In the entire field, I can see that this spot, when I close this eye, I can see that this spot is black. So when the patient appreciates that spot, we call it as positive scotoma. And what is a negative scotoma? A negative scotoma is something which exists but the patient doesn't appreciate. Why? Because it is being covered by the surrounding area. So that is a negative scotoma. So we need to understand this concept of scotoma because this is a very integral part of the visual field analysis. So what is a scotoma? Scotoma is a non-seeing area in the visual field. So what is a relative scotoma? Relative scotoma is something which disappears on increased brightness. What is an absolute scotoma? Which stays despite increased brightness. And what is a positive scotoma? Positive scotoma means patient appreciates, and negative scotoma means sorry, the patient doesn't appreciate. Okay, so these are the different types of scotoma. So we understood what a visual field is. We understood the concept of scotoma because it's important in understanding the visual field analysis. Now let's understand another important concept which is important in understanding the visual field. That is the concept of blind spot. So what is blind spot? It is nothing but the field version of the optic disc. In the retina we call it optic disc, in the field we call it blind spot. Because the visual field is actually the reflection of the retina and the optic disc. The retina, whatever the way the retina and the optic disc is performing, that will be reflected in our visual field. So the entire visual field is the reflection of the retina and the optic disc. The retina and the optic disc findings are objective findings, which means the doctor sees, and the visual field changes are subjective findings which the patient appreciates. Patient appreciates and we see what the patient appreciates in the report. So what is blind spot? Blind spot is nothing but the optic disc in the field. When the optic disc goes to the field, it is the blind spot. Okay. And now I want to tell you another concept. And what is that concept? That concept is the fact that the optic disc and the retina forms the visual field, but here there is a twist. And what is that twist? That twist is the twist of opposite. What is this twist of opposite? The twist of opposite means the nasal retina sees the temporal things, the temporal part sees the nasal things, the upper part sees the lower things, the lower part of the retina sees the upper things, which means whatever we are seeing in the visual fields are actually crisscross, just the opposite of each other. Thus, the optic disc will have its reflection temporally. The optic disc is present nasally, so it will have its reflection temporally. Anything that is present superiorly will have its reflection inferiorly. So now the optic disc is present nasally, so its reflection will be present temporally. Now the question is, what do we see in that optic disc temporally? In the temporally, we see a blind spot. I mean, when we talk about optic disc, we see a blind spot. The reflection of the optic disc is a blind spot. You'll ask, ma'am, why is there a blind spot because of optic disc? Because obviously the optic disc doesn't have any nerve fiber. It's just the pathway of the nerve. There is no image formation in the optic disc. Since there is no image formation in the optic disc, the reflection of the optic disc in the visual field is the blind spot. And the way we say that by looking at the optic disc we appreciate which eye it is, the moment we see that the optic disc is a particular side, we know that that is the nasal side. In a similar way, in the field report, just by looking at the blind spot, we can know which eye it is. Why? Because the blind spot is always present temporally. Okay? So this is the importance of the blind spot. The fact that it is the reflection of the optic disc. The optic disc is present nasally, so blind spot is present temporally. But why is there a blind spot? Because there is no image formation in the retina. This helps us to know the side of the eye when we look at the report. And another thing I want to tell you, whenever we read the visual field, we have to understand that it is our field. Just remember this. I mean, when I am reading, because every time the direction of the doctor and patient are opposite to each other. For example, if I'm examining this patient, then I'm looking at this patient, the patient is looking at me. So the direction of the doctor and the patient is opposite to each other in every examination. But in visual field, the patient sits in the same direction as that of the doctor and appreciates. So we have to understand that when we are reading the visual field report, we can imagine that it is a visual field report of our eye, and that will help us to understand whether it's the right eye or the left eye. Fine. So optic disc reflection, visual field, optic disc present nasally, visual field present temporally, no image is formed in the blind spot. That's why it is known as the blind spot. Fine. So the concept of blind spot is very important. And here, if you try to understand, you see that that this is the visual field and this is the blind spot. Basically, this was the optic disc which is present nasally, but the blind spot is formed temporally, just the opposite. So everything is just the opposite. Fine. Next, another concept we have to understand before we move on to the visual field changes of the glaucoma, and that is the concept of isopter. What is the concept of isopter? The concept of isopter are the imaginary lines in the visual field which has equal sensitivity, which means there are so many lines. You see that there are so many lines, and in my visual field there will be a particular line which has equal sensitivity to light. So that particular line which has equal sensitivity to light forms an isopter. Then we will have another line which has equal sensitivity to light, that will form another isopter. So in a similar way, every line which is formed because of equal sensitivity to light, they form the isopters. This is also important because when we look for the visual field changes, this isopter contraction is the first thing to happen. That's why we need to understand the concept of isopter. Now that we understood what the visual field is, we understood the fact that the visual field and the optic disc are opposite to each other, we understood the concept of blind spot, we understood the concept of scotoma, we understood the concept of isopter. Yes, another thing, now when we talked about scotoma, the relative and the absolute, the positive and the negative, there is a question for you. What kind of scotoma is the blind spot? Is it an absolute scotoma or a relative scotoma? Well, it's an absolute scotoma, because even if we increase the illumination, that scotoma is going to stay. Another question, is it a positive scotoma or a negative scotoma? It is a negative scotoma because the scotoma exists, but do you know that you have a scotoma? Do you ever see a black spot in your eye? No. That's why it's a negative. It's an absolute and a negative scotoma. Okay? So these are the two things which you need to know about blind spot. Now, let us see the changes that happens in the visual field when the patient has glaucoma. The first thing to happen when a patient is getting glaucoma is an isopter contraction. What is an isopter contraction? It means the amount of visual field that we had, that shrinks a little bit. For example, I was seeing till this point when I am looking in the center, so that gets shrinked. With bearing of blind spot. It means it doesn't come near the blind spot. The blind spot is not affected, but there is an overall constriction of the visual field, which we call is isopter contraction. So this is the earliest change to happen, which is an MCQ, which is important for you. It is non-specific, again an MCQ. Even though it is the earliest change, it is non-specific. Why it is non-specific? Because the patient doesn't appreciate it. Even if it is present, the patient doesn't know that such kind of thing exists. Okay, so this is the first change to happen in glaucoma. So what is it? The first change? It is isopter contraction with bearing of blind spot. Few important things about it is that it is non-specific. Sorry, it is non-specific. It is earliest, and the patient doesn't know about it. Okay, so these are few important things about the first change that happens, and that is the isopter contraction. Now, what is the second thing that happens? The second thing that happens in the visual field is the paracentral scotoma. Okay, so what is paracentral scotoma? Well, we have this different kind of nerve fibers, the superior arcuate. So if we talk about the nerve fibers, well, these are the superior arcuate fibers, these are the inferior arcuate fibers, these are the superior radial fibers, these are the inferior radial fibers, these are the papillomacular bundle. Okay, so when we talk about all the nerve fibers, the first nerve fiber to be damaged are the arcuate fibers. Okay, the first nerve fibers to be damaged are this one, the arcuate fibers, the superior and the inferior arcuate, but usually the inferior arcuate fibers are damaged first. So just because these fibers are damaged first, we will see its reflection in the visual field, and since these fibers are damaged, we will see a change here, and this change is known as the paracentral scotoma. This paracentral scotoma is important. Why? Because this is the first clinically significant change. Paracentral scotoma, because the patient will know that there is something happening. So this is the earliest clinically significant change, which is an MCQ. Okay, this is important because this is the earliest clinically significant. Even though isopter contraction has happened, but that was non-specific and the patient didn't know about it, but this is clinically significant, specific, and the patient knows about it. That's why it is important. Now what happens? Now the damage gradually increases with time. There is a damage, but now there is a small damage, and this damage grows, and it grows till the optic disc. So there is a growth of this damage, and it grows till the optic disc. And when there is growth of this damage, the nerve fibers gradually damage and reach the optic disc. In a similar way, here in the field also we will see its reflection, and this damage comes and joins the blind spot. The damage is increasing in the optic, retina. That's why that damage is also increasing in the visual field. And what is this? This is a saddle scotoma. What is that? That is a saddle scotoma. So the first thing is a paracentral scotoma, and the second thing is a saddle scotoma. Okay, why do we call it a saddle scotoma? Because it looks S-shaped. Fine, just because it looks S-shaped, we call it a saddle scotoma. This is the second thing to happen. Now what happens? We know that the damage is happening. So now what happens is, here the damage has happened and it has reached this point. So first paracentral happened and then saddle happened, and now what will happen is it will extend to this side. So now it will extend to this side. And just because there will be extension to this side, this will form an arc known as an arcuate scotoma. That is the third change that we see in the visual field. So the third thing is an arcuate scotoma. Next what? Next is when we see this change, so inferiorly, we will also see this change superiorly. So inferiorly we have seen this change. So superiorly also we will see this change. And when we will see this change inferiorly as well as superiorly, how does it look? It looks like two arcs. And when there are two arcs, what will you call it? You will call it biarcuate scotoma. Since there are two arcs, that is the fourth thing to happen, and that is biarcuate scotoma. Fine? This happens and then this happens, and that forms the biarcuate scotoma. In the biarcuate scotoma, why don't we call it a circular scotoma? Why do we call it a biarcuate scotoma? Because it never forms a circle. Instead, it forms two arcs, and these two arcs join at a step. You see that there is a step here. We actually don't see a circle, but we see two arcs, and these two arcs, they join each other and they form a step which is known as the nasal step. Okay. So there is formation of nasal step. So this is the fifth thing to happen in your visual field changes. And then finally what happens as this visual field changes grow, gradually the central vision also goes away. The last thing to go away is the nasal fibers in the retina, which correspond to the temporal field. Because the nasal fibers are very resistant, so this temporal crescent stays. Everything gets damaged except the temporal crescent, and finally the temporal crescent also goes away. Okay, so finally, so first what happens is, first we see a tunnel vision, then the central field is gone, central field goes away, and finally the temporal crescent is the last to go. Why the temporal crescent is the last to go? Because nasal fibers are the last to get damaged. Since the nasal fibers are the last to get damaged, so the temporal fibers are the last to go. Fine. So this is how the damage in glaucoma happens. Now we understood that what are the changes that happen in the glaucoma. We need to understand something which is known as perimetry. We understood that the changes have happened, but now we have to understand that how will it manifest? Like, how do we examine the patient and how do we know that the patient is having such defect? Because everything the patient is seeing, and we have to understand that the patient is seeing some changes, which means we will have to examine the patient in a way where we can read the report and say that, oh yeah, these are the changes that has happened, and that is being done in perimetry, and that we will be learning in the next lecture. Thank you.